Bismillahirrahmanirrahim. Today our topic of discussion is the management of gestational trophoblastic disease. This is the guideline of the green top guideline which we are going to discuss for our theory along with the MCQs. I will try to do the MCQ today. If we don't have a time, then we will do the MCQs tomorrow. So our discussion we will start there the MCQs which in between I will tell you which are the most important MCQ along with the recalls. Okay ji. So the first thing is that how the gestational trophoblastic disease is presenting, or how the complaint is there. So we have to remember three things our mind about this thing. What are the symptoms? The question is that what are the symptoms patient can present. So the MCQ can come like this, that the most common presentation, less common presentation, and where very rarely presentation. So please remember these things in your mind, because these are the three different presentation which they will give you a scenario. They can give you the scenario that the woman, she has been came with a complaint of irregular bleeding and positive pregnancy test, and supporting ultrasound evidence is there that she is having a molar pregnancy. So these are the common symptoms, or the less common symptoms, or very rare symptoms. So we have to give the answer. The answer will be A means most common symptoms. So if we will consider these, we finish our things. Okay, the less common symptoms will be, that means including that one, that she will present with severe hyperemesis, okay, and excessive uterine enlargement. What is this meaning, uterine enlargement? Because in the molar pregnancy, height of fundus is more than the gestational age. She can present with hyperthyroidism. Why hyperthyroidism? Because in the hyperthyroidism, beta serum HCG level, I'm talking normally, I'm not talking about TSH will be increased. If she is pathological, there is something else, but normally I'm talking about physiologically. If she is having a bit molar pregnancy, so in that one also, because of beta serum HCG increase, there will be hypothyroidism, but there is a limit. After the symptoms is gone, this will come back to normal, this TSH. So that's the reason he is telling it about this thing. We will get about that TSH, hypothyroidism, and the early onset of the preeclampsia. Preeclampsia means they will present with preeclampsia, sign and symptoms of that one. And abdominal distension, I already told you that abdominal distension, because there will be two reasons will be that she has a vesicular moles in her pregnancy. Height of fundus is always increased. You have to remember that one thing. And the second thing, that abdominal size is increased because of the thicker luteal cyst. So the question, MCQ question, because my friend, sorry for that thing, I'm trying to tell you the MCQs along with that, the guideline. Okay, so the thing is that the question is that the patient present with a molar pregnancy and she has a abdominal distension. The option will be that because of that she is having a molar pregnancy, or she has a thicker luteal cyst, or option A and B. The C option will be that. So we will take the option will be C, because it can increase, because of that abdominal distension is increased because of the molar pregnancy along with the thicker uterus. So this will be our answer is that one. So the last scenario of the MCQ will be that one, that the patient present with the seizures and she is having hemoptysis. This is a very rare metastatic symptoms of the molar pregnancy, when it will go the gestational trophoblastic disease. So this is a rare presentation. So in the MCQ, what can we have it here? In the MCQ, the question which I am telling you, because this question I already make it, but we will do it this MCQ if we have a time today, otherwise tomorrow. So what we get it here, so we have to give the options that this is because she is having hemoptysis or seizure, or option A and B. So most important one is the hemoptysis. Most commonly they will present, and the seizures one. If they give us both options, hemoptysis and the seizure, so we will take these options A and B. Okay, if they give us separately and they can give us A and B or all of the above, they can say it. So then we can say all of the above. So this question we finish it here. Okay, so now other thing is there, if she, what is the definitive diagnosis? And this is very, very important MCQ, and this, they love this MCQ. This is their favorite MCQ. So they are saying the diagnosis of the molar pregnancy, we have two definite that diagnosis. It can be diagnosed clinically, but the definitive diagnosis with ultrasound also. But the definitive diagnosis is the histopathological examination of the tissues which we have it there. So the definitive diagnosis by histopathological examination, it not with the clinically, and it not with the ultrasound. Definite diagnosis will be with the histopathological examination. So this is very important MCQ for the recalls. Mostly they will give this recall, most of them. So I'm telling you the recalls along with the recalls, exam recalls, and the MCQs of this topic. Okay, so what we have another thing is that how we will, what is the treatment of the molar pregnancy? The treatment of the molar pregnancy is the suction curettage. This is the method of the choice, the first one. But for, because we have to know one thing before we will continue, that there are two type of molar pregnancy, complete molar pregnancy and the partial molar pregnancy. We'll do it later on down is there the explanation, but we are discussing the management. Here the management is suction curettage we will do if it is a complete molar pregnancy. Okay, we done, finish the business. But if there is a partial molar pregnancy, see, complete molar pregnancy means uterus is full of this vesicle, okay, because there is a trophoblastic changes going on. So the uterus will be changed. Uterus is going to be big because of the this placental changes, villi जो है ना, they are becoming like a vesicles. But it is full, there is nothing more than that one, because there is no pregnancy in the complete molar pregnancy. Please, we have to remember that one. Okay, but in the partial one is that one, what happening, there will be a pregnancy and there will be a placental changes which going to make it the vesicles. Okay, so both things are there. This is the meaning of the partial molar pregnancy. Complete means complete, nothing will be there, only vesicular mole. But partial means both things we get it, baby and the placental changes. So in that one, because in the complete we will do the suction evacuation, but the problem is that in that partial mole the baby is there. So suction curettage is not an easy job. It is very hard. So it has to be done by the consultant. He is the one, even the complete molar, he is the one who is responsible, experienced one. Okay, he is the responsible for the suction curettage for that time. So but the thing is that in the complete one, partial molar pregnancy, we have to do with the medical treatment, termination of the pregnancy. Medical means because we have to give her some tablet medicines. So it, the os will open and maybe it will, the baby will come out along with the placental changes. If she remaining is there, so at least we have a chance that the, it will not hindering the suction curettage if the baby is still there, because it will be a very difficult procedure and the risks are more, perforation risks are there. Okay, the most important risk is the perforation and the hemorrhages is there. I think it is clear for you. It is clear who is ever it is. If it is not clear, please let me know. Clear? Okay. So now we have it here. Another thing. So we already know fetal parts and this thing. What will our treatment of the choice? Okay. Now we will come to the. Now we done the suction curettage. Whatever we done it. Now the thing is that anti-D. Anti-D we have to give it. Okay. In some cases we don't give the anti-D, but here we have to do it because we are doing the surgical removal. Anti-D if she is Rh negative. Okay, the important question, the another important question MCQ, and this is a very important recall, is that before we will go for the removal suction curettage, did we do the preparation for the cervix, means if the os is closed. So we will do the preparation for the suction curettage. So we can do it 1 hour before that, 1 or 2 hours. Why we are not doing routinely? after assessment of the cervix. It's not an routinely we will go for the cervical ripening any tablet prostaglandin. We don't give it because there is a risk of the this immobilization, because this vesicular mole, it can be through the blood, it will go in the body, and the most important problem is they will get it emboli in the lungs, so she will have an increased risk of mortality. That's the main reason. But 1 or 2 hour, it is not so much crucial time. It can be done it, but after the consultation, consultation advice. Okay, so this thing we finish it here there. Immediately we can do before removal of that one, and then she can if she another question is that when we are removing it. When we are removing this molar pregnancy suction curettage, at that time oxytocin, can we give the oxytocin? Yes, oxytocin can only be given if she is having a hemorrhage. Without hemorrhage, if it is okay, the suction curettage which we done, there is not so much bleeding, so we don't give it, because the same another reason, the same reason, that immobilization means it will go up in the body and it will be immobilized. The problem will be there because it can change to the malignant form. That's why we are afraid of that thing. So okay, we finish up to there. Infusion can be given only that one, we already told you, if because of that risk. But if she is having a heavy bleeding, we can do it. Okay ji. There is a one thing is that if the patient is hemodynamically unstable, then we have to go quickly for the suction curettage. With persistent bleeding or hemodynamically unstable, that time we do the suction curettage, that one. Okay, we done that one, we finish our this thing. But mostly if the patient coming in the clinic and we diagnose that she is having a GTD, so we make a referral for the secondary care. Okay, so we done that one. So every after suction curettage, the tissues we have to send, for the histopathological examination. Why we are sending it? Because whether it is a medical or the surgical removal of that this molar pregnancy, we have to send the histopathological one. Why we have to do it? To exclude that there is no pathological changes, means there is no cancer cells are there, and if no fetal parts are identified at any stage of the pregnancy, so we have to exclude that one. Okay ji, so that's the thing. Okay, and the most important thing is there that after we finish that our medical termination or the surgical termination, we have to make a follow-up, and this follow-up after 3 weeks of this miscarriage, we have to do the pregnancy test, urine pregnancy test. What it is this one. Okay, routinely we are not sending the histological examination this one, these tissues, but like therapeutic abortions, we don't send it. Okay, because we already know the baby is there, everything is fine. But if we don't find any baby, either that one, then we have to send that tissue. This is the thing they want to clarify that one. And medical termination, if we are doing, so after that medical termination, we have to do that after 3 weeks, the urine pregnancy test of that procedure. But now we finish our this molar pregnancy and this. Now he wants to do this gestational trophoblastic disease. What is the meaning of this gestational trophoblastic? Because sometimes they will change into the 90%. They are not nearly 95%. It will be okay. This revert to the normal, but sometimes the 5% changes will be there. They will go into the gestational trophoblastic disease. So if they are changing, so how we know that they are changing the gestational trophoblastic? For that one, we need a what we call it, because we have to do the follow-up for that one of the after suction evacuation follow-up for this complete and the partial molar pregnancy follow-up. What we are doing it beta serum HCG with the serum, or we have to do in the urine. But there is in the GP center, the patient will go and he is the one there weekly or twice weekly. They are the one who is collecting their sample, and they are sending to this trophoblastic center, and they are the one who is going to follow up. If the level is not coming down, so it is going up. So it means if she is having a elevated SCG level instead of going down, so it means she is start to have a disease GTN. It is GTN. We are diagnosing that she is having a GTN. So what investigation we will do if she is non-molar pregnancy, means if she start to have, means like the threatened miscarriage or the miscarriage, she a complete miscarriage or incomplete miscarriage, she a uterus is evacuated but still she is bleeding. If she is persistent vaginal bleeding more than 6 weeks or that one, then 3 weeks for abortion. But for the pregnancy, if she completely term pregnancy she delivered, after 6 weeks she is still having the bleeding, so she has to go for the investigation. And the most important investigation, she beta serum HCG level, and it means she is going to have a GTN. This is a very very important MCQ. Okay, after that urine pregnancy we will perform that what I am telling it, 8 week na, 8 week for that one we will do that thing. So the we will he is telling, okay, what will be the symptom if this disease is metastatic, means metastasis GTN means she is start to have a this means malignancy. This is malignancy changes she start to have. So what are the symptoms? She can have a dyspnea, she can have a blood in her coughing one, hemoptysis, or she has a new onset of the seizure, or she is having a paralysis. So these are very rare symptoms she can have it. These are the symptoms of metastatic disease of GTN. It will change. Molar will change to the GTN, neoplasm, gastric trophoblastic neoplasm. This we call it that one. Okay. So the biopsy, whatever, if we will get the deposit, we can get the biopsy. So it will, if it is in the vagina, so we can get it. The he's telling one thing, very important point, very important recall, very important recall. Please don't miss that recall. The recall is that one. The patient has, they diagnose that the patient having a metastasis. Okay, the question I'm telling you. Means she has a GTN. GTN, they find it out there is a one nodule in the vagina. So the option they can give is we will do the biopsy, or not to do the biopsy, or leave it alone, whatever it is, this biopsy, and we will refer her to the this one trophoblastic center. Okay, so the thing is that she is not a candidate to do the biopsy because in the vagina she will start, if we will do the biopsy of that area, she will start to have a major hemorrhage, which is unacceptable thing. Major hemorrhage, you cannot control that one. But this gestational trophoblastic centers, they have a group of the people which we call multidisciplinarian. They are the one who is going to decide what to do. We are not the one, because we don't have a facilities and we don't have a things for the, means I am talking about normal, because GTN is a tertiary center. They are the one who is going to decide for that one, because they make a special center for GTN. So they are the one who is doing that one. So he say now the other MCQ, very important MCQs, what we have it here, different scenarios they are going to give you, the different scenario. He say, okay, we manage the case like other cases. If we found out that along with this atopic, she is having a atopic along with the GTN, so what we are going to do, how you are going to manage it? We will refer her to the center. We will send her to the center. We are not the one who is going to make it anything for her. It has to be referred. Send her to, if we get that tissues, this tissue we have to send it for the pathological review. If we get it after atopic, we remove the atopic, but still she is having the this GTN. So we send that tissues and we will send her to the refer for the this one expertise for that one. Another question is that if we have a viable pregnancy and she is having a coexistent molar pregnancy, so how we are going to manage it? So if there is a diagnosis of a viable twin means one inside one outside, so the same we have to refer her to the GTN center. Okay, and they are the one who is going to manage it. They will counsel about the risk of prenatal morbidity and outcome of it. They are the one who is going to manage it. Okay, Then we have to do, if there is a prenatal invasive cancer, we will have to do the fetal karyotyping when it is unclear that it is a complete molar or existing normal pregnancy. This one we do karyotyping, it will help us in the diagnosis of that one. Other question is very important question, that how you are going to manage a GTN. GTN, how we are going to manage, because you know this treatment what we are going to manage it. There is a question. First question is some. Sorry, we will go to management before, but first thing we have to say, after the following diagnosis, after we diagnose that it is a molar pregnancy or GTN, which patient we will send for the referral to the registration to the GTN center. What are these are the cases? This means complete molar or partial molar pregnancy, twin pregnancy with complete or partial molar pregnancy, and then she can have PST and ETT and atypical PSN. This all upstairs is written what is PCN and this thing. You can find it up here. These are the short form. Another thing is that the follow-up, and this follow-up is very important one. For if it is a complete molar pregnancy, SCG level has to become normal within 56 days of the evacuation. Okay, so after if it become normal, so we will follow up 6 monthly to the date of the uterine removal, means uterine this we will remove that molar pregnancy from the date. If 56 days has become normal, but if within 56 days is not become normal, okay, then we have to continue to this one 6 monthly, and the time of 6 monthly when it is become normal, at what time, that time we have to give to her, that time we will take it. Then we will this whatever time she it came normal, this we will take it as that time, and then we will continue for the normalization of that point. From the normalization 6 monthly follow up we will do it, that one. But it has to be coming down, it is not supposed to go up. If it is start to go up, then there is a problem, then there is a GTN going on. We are talking about the molar and the partial pregnancy. When it follow up, we have to stop our follow up. But if it is a molar pregnancy, we have to do when it will become normal, we will take two sample 4 week apart. If they are normal, then we don't need any more follow up for that one. But there is a difference between the partial and the complete molar pregnancy. Okay, ji, clear for you people, or I hope it will be clear. Things are there. The treatment of GTN, they are saying about the thing, because see they are giving the score of the GTM. There is a one score table, is that one. I will show you. This is the table. They are giving the score of, according to that table, my dear. So you have to remember some words if you want to remember that thing. So this table I'm showing you, this is the table. FIGO scoring system. This is called the FIGO scoring system. I will try to make it on the group. This one there, age, a recent pregnancy, and interval of the from the end of index pregnancy, pre-treatment, what is the serum SCG level, what is the size of the tumor, size of metastasis, number of metastasis, previous failed chemotherapy. You just only remember one thing. We give this scoring. With this scoring, if the score less than 7, so she will receive one single monotherapic agent, chemotherapic agent. What will be the chemotherapic agent? Methotrexate. But if this score, that is a score in front of us, if it is more than 7, then she has to receive multiple agent, okay, multiple chemotherapy agent. This is called AMACO. So what are the name this AMACO? This will we have to understand the name of that. This only the name, please, because we don't have so much time that we have to remember each and everything. Okay, so this is we have to finish up to here. I will try to put it, and I already told you the MCQs about this. And I already told you if she's RH negative, she has to receive the anti-D, my friends. So this is, I think this is we finish. Okay, yes. That's some another thing here. She what means she didn't we done for her the DNC, everything done for her. Then now she, if she is abortion case, she want to she want the this contraception. So the contraception, because you know previously they are saying something else about the contraception. Now they are saying she can receive the contraception, but try to not to give her the estrogen along with estrogen. Pop, she can have it. She can have a this one, this long acting. Okay, contraceptive pills, she can have it, but try to avoid the with the estrogen, exogenous estrogen. Try to avoid that one. Okay, ji. She can receive it when the level become normal. She can receive it after levels become normal, but until unless the levels are normal, she has to use the condom. Okay, or she can have a pop. Okay, this progesterone, she can have it. Another question is that she can receive HRT. Okay, HRT can be used the same thing when the level of SCG level become normal. That's the only thing. And this, Alhamdulillah, we finished today this Molar pregnancy. And inshallah, the MCQ I already told you along with that one. Separately, we will do the MCQs tomorrow. But the most